Good evening, everyone. Respected Chairperson Sir Dr. Sanjeev Singh Rawat and esteemed panelist, uh, esteemed faculty Dr. Kishan Chuk Sir, Dr. Ketan, and Dr. Ansula, and all the dearest delegates. Today is a very important day in from the perspective of IAP NRC also. This is World Pneumonia Day. It is observed every year 12th of November. So this year the theme is child survival, World Pneumonia Day's theme, and it actually emphasizes that it still is the leading cause of death out of infectious diseases, especially in under 5, and mortality and survival. These two things, they are still the concern globally. And dear friends, uh, of all the advancement and of the wonderful antibiotics, antimicrobials that is available, still why it is the leading cause. And these four components that have been identified, they are not related exactly to the treatment aspect, which is nutrition, clean air, then vaccination and availability of healthcare. So these four, they are not related to the management treatment aspect. So in observance of that, today's very important CME, I request our chairperson sir, Dr. Rawat sir, to have the welcoming address. Thank you.
Thank you, Dr. Modi. Good evening, respected faculties, for this important CME on pneumonia on World Pneumonia Day. All the delegates who have joined today evening for this session. A warm welcome from IAPNRC. As Dr. Modi has told you, the theme for World Pneumonia Day, which is observed every year on 12th of November, is child survival, which indicates the importance of this disease as an important cause of morbidity and mortality in children. Uh, Global burden disease data from Lancet series says that in 2023, 2.5 million people that died of pneumonia worldwide. Out of them, about 6 lakhs were children below 5 years. Even in India, the things are very scary. About 15% of children below under 5, they die because of pneumonia every year. And in terms of total number, this comes to about 1.4 lakhs per year, indicating a huge burden of death caused by pneumonia. The causes of these deaths are rapid urbanization leading to overcrowding in homes, outdoor pollution, indoor pollution like cooking by biomass fuels and other causes, lack of vaccination, lack of access to healthcare, and most important, malnutrition. 60% of deaths due to pneumonia, they have got malnutrition as an underlying cause, indicating the importance of this particular factor which can be prevented. Now, if you have to impact, because all the countries who have marching towards SDG by 2030, if they want to attain the goals of sustainable developmental goals, they have to impact this particular malady. And it can be done only by tackling environmental pollution, indoor pollution, vaccination, tackling malnutrition, breastfeeding for the initial 6 months, exclusive breastfeeding, and access to antibiotic and healthcare, which is again a very important cause. So IAPNRC considers this malady as a very important part of its activities, and we observe this day every year with a CME, and we try to update our members regarding this important disease. So this year we have got 3 senior and expert pediatric pulmonologists from across India to discuss various aspects of pneumonia. We have got Dr. Ketan Kumar. He is from AIMS Bhubaneswar, and he'll discuss about changing epidemiology. As you know that initially, for 10 years back, bacteria used to be a very important cause, and now the things are changing, and current evidence indicate that virus are the most important cause of pneumonia. So Dr. Ketan Kumar uh, will guide us what is the current scene in epidemiology of pneumonia. Now, Dr. Anshula Tayal, she is a pediatric pulmonologist from Manipal Hospital, Goa. And as you all know, appropriate treatment of pneumonia depends upon the etiology. So if you know the etiology, you can treat pneumonia in proper manner. So Dr. Anshula will guide us what are the correct etiology of pneumonias, and how can you diagnose them? Because again, diagnosing and knowing what is the etiology, again, that is a very important aspect of treatment of pneumonia. Dr. Kishore Chuk, as you all know, he is a senior pediatric pulmonologist from Fortis, Gurugram. Management of pneumonia, as you all know, the last guidelines by IDSA, they were made in 2010. And after that, there has been no new guidelines, but there are a lot of new papers indicating that there are a lot of new changes in management of pneumonia, where short-term chemotherapy is now a norm for management of pneumonia. So Dr. Chuk will guide us and will tell us what is new in management of pneumonia, so that we manage pneumonia in a more effective and a more evidence-based way. So to start the ball rolling, I'll request Dr. Modi to take over and start the session, please. Thank you very much.
Thank you, sir. Without much ado, I would invite Associate Professor AIMS Bhubaneswar, Dr. Ketan Kumar, to open the batting with the topic changing epidemiology of community acquired pneumonia. Over to Dr. Ketan Kumar, please. Thank you.
Thank you, sir. Thanks a lot. I'll share my screen. I hope my slides are visible, sir.
Yes, please.
Yeah, it's visible.
Okay. Thank you, sir. At the outset, I would like to thank IAPNRC, Dr. Rawat and Dr. Modi for giving me this opportunity. Now, I'm supposed to talk about changing epidemiology of community-acquired pneumonia, but I've added a question mark here because I'm not sure what I will be talking about. A lot of that is actually changing or just a reconfirmation of what we already know. So that I will leave for the listeners to decide. Apart from that, there are a few other problems related to deciding epidemiology. So till 3 to 4 years back, we were a part of a raging pandemic which disrupted everything, and the normal chain of communicable disease was disrupted. The incidence of communicable disease actually went down, and we are still kind of getting back on track. We are still not at that stage when we can actually reliably attribute causation to any organism that we have isolated. We don't have those robust diagnostic methods yet. So in light of all that, what I will do is I will talk about the current worldwide and Indian trends. I will focus on the common etiological agents and provide some evidence that is available. I will talk in some detail about pneumococcal conjugate vaccines because this, I believe, is the most relevant change that is currently happening to us, and a bit about viral pneumonia and mycoplasma. I will end up throwing some data at you, but the idea is not to make you remember the data, but rather to convey the magnitude of the problem. So this is what WHO said in 2017, and this is still relevant. They said that as much as 1/3 of the infectious causes of mortality in under 5 was contributed to by pneumonia, around 30%. And the current target is to reduce deaths due to pneumonia less than 3 per 1,000 live births by 2030. The initial target was to achieve it by 2025, but that doesn't seem to have happened. And still in most developing countries, the number is more than 7. So we have a long way to go still. We know there is a huge discrepancy between high and low and middle income countries. And as much as 90% of the pneumonia cases and deaths are concentrated in LMICs. Just a few numbers to put this in perspective. In terms of incidence of pneumonia per child year, it is 4 times higher in LMICs, and 1 in 5 children in LMICs experience 1 episode of pneumonia compared to 1 in 66 in HICs. And the case fatality rate ratio is even higher, which is 10 times in low and middle income countries compared to high income countries. Dr. Modi and Dr. Rawat have already talked about risk factors. So largely there has been no change in the risk factors. This has been taken from a recent report on pneumonia in India. So if you look at this table, the most important seems to be child malnourishment along with vitamin A supplementation, which is again a surrogate for malnutrition. This is followed by faulty or prelacteal feeding, again we all know, and poverty followed by poor educational status of parents. If you look at protective factors, early exclusive breastfeeding seems to be protective. So this much is about the current burden. Now I'll move on to etiology, which will form the bulk of what I'm going to talk about. This table I have actually taken from the current edition of Nelson, and this seems to be holding true for past a lot of years and might hold true for the next few years as well. So I will not talk about neonates, but if you focus on the second row, that is the young infants, viruses seem to be the most frequent pathogens in order of frequency. RSV precedes everything. And then come rhinovirus, parainfluenza, influenza, other viruses, followed by H influenzae, both vaccine type and non-typeable, and Streptococcus pneumoniae. As we move ahead in terms of age, the viruses are still the major players, followed by Streptococcus pneumoniae, H influenzae, and there is some mention of mycoplasma. In the age group of more than 5 years, which I will not be talking about today a lot, mycoplasma seems to be predominating, followed by Streptococcus, H influenzae, and the other viruses. Now, in terms of evidence, does this still hold true? So, all of you must have already heard or read this study. This is the Pneumonia Etiology Research for Child Health study. This was published in the Lancet in 2019. This was one of the largest studies about childhood pneumonia etiology in the recent years. So what the authors did was they enrolled children in the age group of 1 to 59 months with severe and very severe pneumonia according to the pre-2013 definition of WHO. The study was conducted from 2011 to 2014, and there were 9 sites in 7 countries. All of these countries were in Asia and Africa. The thing to remember is that India was not a site, and among Asian countries, the 2 countries which were a site of the study were Bangladesh and Thailand. The common theme between all these sites was that they were routinely using pneumococcal conjugate vaccines at the time the study was conducted for at least 2 to 3 years. What was different about this study was they used a case control design, which allowed the researchers to actually attribute a odds ratio to the pathogens they isolated, or in other terms, they were able to determine to some extent whether isolation can, whether causation of pneumonia can be attributed to the isolated pathogens. They enrolled some 5,000 cases and approximately 5,000 controls. Out of half of the cases had positive chest X-rays. And they collected nasopharyngeal and oropharyngeal swabs, blood from both the groups, and sputum and other samples were collected as and when indicated. They did culture from all samples, and a 33 pathogen quantitative PCR was done from all. So what did they find out? This first line is probably the most important finding that they had, and just re-emphasizing what we saw from the textbooks, that viral pathogens still constitute the major chunk of the causative agents, which is more than double of what is caused by bacterial agents. RSV still leads all the pathogens, and it accounted for around 31.1% of the distribution. We can see here RSV is far ahead of everything else. In as many as 59% of the cases, they identified multiple pathogens. So this is again something that we need to take care of and we need to keep in mind. Other common pathogens following RSV were rhinovirus, metapneumo, parainfluenza, and then comes the role of Streptococcus pneumoniae and H influenzae. That did also end up isolating M tuberculosis because they collected gastric aspirate and did PCRs. Apart from this, they also looked at etiology in terms of age. So they found out that RSV, Staph aureus, parainfluenza, Bordetella, and Pneumocystis jirovecii, they were all more common in children less than 1 year of age, whereas strep pneumonia and rhinovirus were more common in children more than 1 year of age. When they looked at severity stratification, as expected, Streptococcus pneumoniae and Staph aureus were commoner in very severe pneumonia, whereas the viruses were more common in severe pneumonia. In other words, we can say that the bacteria were found to be more relevant to more severe disease. So this is from the Perth study, which was a multi-center global study. What is happening in India? This is a report from 2019 to 2021, and we are still having 1 case of pneumonia per second in our country. Pneumonia accounts for about 18% of under 5 deaths. We are the second largest contributors to the global burden of pneumonia, second only to Nigeria. And compared to 2015, the prevalence has actually increased slightly. In 2019, it was estimated to be 2.8%. And one of the reasons for that, which was put forward, was that it was because of the disruption caused by COVID. So this is another large study. This was published in 2017, the Gabriel study. And this is important because this had India as one of the sites. The study duration was almost the same. Study age group was almost the same. What they did was they included children who were actually hospitalized with pneumonia with radiological confirmation. And they involved 9 sites. Lucknow and Pune were the Indian sites to be involved. The design was same, case control design. And they used nasopharyngeal swabs and blood and used a culture as well as reverse transcriptase PCR. They ended up enrolling around 900 cases and 900 controls. So what they did was they reported population attributable fraction, or in other words, the amount of pneumonia in the community that can be attributed to each organism. And here we can see that Streptococcus pneumoniae leads the list. This is followed by the other common known culprits: RSV, rhinovirus, metapneumo, influenza, parainfluenza, influenza, and there is some mention of mycoplasma as well, small, but yes, it was mentioned. So what makes Streptococcus pneumoniae more common in this population compared to the Perth study? There are a few reasons which have been put forward for that. These were sites where PCV had not yet been started, in contrast to the sites included in the Perth study. These were children who were hospitalized, all of them. So it is possible that they had more severe pneumonia, and we know that strep pneumonia is associated with more severe pneumonia compared to viral causes. Also, the age included in this study was found to be slightly higher than the Perth study. So these are some reasons that the authors have put forward why strep pneumonia was found more common in this study. If we talk about India, 2 sites were there. So at Lucknow, viruses were the common causes, including rhino, parainfluenza, RSV, and H influenza. Whereas in Pune, apart from strep pneumonia, the rest appears to be the same. Another large study, this was published in 2015, conducted during almost the same duration. The center here was Chandigarh, and children in the age group of 1 month to 12 years with WHO pneumonia were included. Collected samples were blood and nasopharyngeal aspirate. While culture was done in all, PCR was done in 20% of these samples. And altogether 428 NPA samples were processed. And again, important thing, out of these 428, as many as 82% showed more than one organism. And this is the distribution of the yield from NPA, in which S. pneumoniae seems to be leading the race, followed by H. influenzae, RSV, Staph aureus. One odd thing about this study was that CMV seemed to be quite common, and this was something that has not been seen in any other study. So this is the current burden, and this is the current evidence about etiology. What changes are happening and what changes we can further expect in future? So we know we have recently Hib vaccine is already a established part of our universal vaccination program, but pneumococcal is something that we have recently become used to. So what changes it is going to cause, I will talk about that in some detail. We have been increasingly using molecular detection method that of course does not change the etiology, but makes us more aware of organisms which we were not talking about previously. And then there is a more use of non-pharmaceutical interventions like increased use of hand hygiene and masking. So let's talk about the conjugate pneumococcal vaccines. The first vaccine which was licensed was PCV7 and was introduced in the US in 2000. Following this, what was seen was there was a rapid detection in all-cause pneumonia. There was a reduction in pneumococcal pneumonia and overall invasive pneumococcal disease. This was seen immediately after introduction, as we can see in here, immediately after 2000. A similar decline was seen in the UK when it was introduced in 2006. However, as we can see here, in both age less than 2 years and 2 to 4 years, the decline was much less gradual seen in the US. Decline was also reported from other continents, including Australia as well as Europe. So this was the good part. What happened after a few years was that the people started realizing that there was a rise in pneumonia caused by serotypes which were not covered by PCV7, and these were predominantly serotypes 3 and 19A. Apart from that, there were also increased reports of empyema, which were attributed to non-PCV7 serotypes. So this is another study from US. This is a relatively small study, probably around 90 to 100 cases. But what they saw was immediately after 2000, there was an increase in empyema cases. And most of this was accounted for by negative cultures as well as Staph aureus. And a similar increase in empyema was reported from other countries and continents as well. So this is when people started realizing that PCV7 might not be the best option, and they started looking at higher valent vaccines. So PCV10 came into existence, in which 3 more serotypes were included, which was followed by PCV13, in which 3 more serotypes over PCV10 were included. And in 2010, PCV13 was introduced in both the US and UK, following which there was a sustained decline in vaccine type invasive disease. There was a reduction in carriage as well, and as a result of which there was some herd effect seen in the adults, and adults were also, as a result, protected. This is again same thing. So what happened after PCV13 introduction in the US? Initially, when PCV7 was introduced, there was a gradual increase in empyema incidence, and after PCV13 was introduced, we can see that there is a decline. And this held true for all the age groups, less than 2 years, 2 to 4 years, and 5 to 17 years. This orange bar is what happened after PCV13, and it is, while there was an increase after PCV7, after PCV13 was introduced, there was a reduction. This was mostly about the developed world. So what has happened in the developing world? There is a systematic review. This was published in 2023. And here the authors included observational studies from sites where the PCV was in use for at least 3 years. Cumulatively, what they showed was there was a decline in highest decline in pneumococcal pneumonia, severe pneumonia up to the tune of 52%, followed by radiologically confirmed pneumonia and all-cause pneumonia, which again underscores the knowledge that strep pneumoniae is the predominant cause of pneumonia. There was also a decline in all-cause empyema. There was no difference in the impact between PCV10 and PCV13. However, we need to remember that in this study, at least, there was no representation from the Southeast Asian region and from the low and middle income countries in the West Pacific region. So now we come to India. What can we expect? What is happening in India, and what can we expect further? So we know pneumococcal vaccine was first introduced in 2017, after which COVID came and further expansion was not possible. Then universal access was declared in 2021 with PCV10, and now a 14-valent vaccine has been added to the program a few months back. It is important to know the local serotypes in the Indian context. So as this study shows, this is from 2016 to 2019. The important serotypes to our context are serotype 6, 14, 19, and some non-PCV serotypes. These are the 2 vaccines that we have currently in our program. The upper one is Pneumocil or PCV10, in which they have additionally included serotype 6 and 19, which should cover for these 2 concerns. And then we have PCV14 or Newbvax, which has further included 2 more serotypes over PCV10, the serotypes 2 and 9. So what can we expect with the introduction and expansion of the pneumococcal vaccine in India? We can definitely expect a reduction in severe pneumonia if we follow what has happened in other countries. There can also be a shift in serotype prevalence. So the serotypes which are not covered by these vaccines may start becoming more common. There can be a shift in age distribution, as the vaccines have been predominantly expanded in the under 5 age group. So the age which is affected may shift more towards adolescents and adults. At the same time, there could be an increase in staphylococcal and other bacterial pneumonia and their complications, but this still remains to be seen. So this was about bacterial pneumonia and the impact of PCV. Now I will talk about viral pneumonia, but before I do that, this is a search I conducted yesterday in PubMed, and I use these 2 words, viral pneumonia. And I want to look towards the left side of the screen, and it shows you the results by year, and we can appreciate, all of us, that since 2020, there has been an explosive increase, not just an exponential increase, it's an explosive increase in literature related to viral pneumonia. Now, this may not necessarily be a bad thing, but whatever we think and talk about, it needs to be put in context. We are probably now more attentive and we are looking more closely at viral pneumonia. So that also might be a cause of why we are getting more viral pneumonias and why the incidence seems to be increasing. Apart from the possible fact that the incidence could be increasing, it is definitely important because viruses do have an outbreak potential. And apart from a few pathogens, we still do not have good, specific, and effective treatment and vaccines. This is a systematic review. This was published in 2022 and included literature published in the pre-COVID years. And this again emphasizes the same thing. Viruses outnumber bacteria in terms of causes of pneumonia. This is more than 50%. And RSV outnumbers everything else, 22.7%, followed by rhinovirus. Now, even in this systematic review, which was quite an extensive one, the authors found that the pool prevalence was even higher when studies with used PCR were compared to studies using other methods. We talk about Indian context. Again, there has been an apparent increase in RSV. These were all studies which were conducted in 1990s from Delhi, Lucknow, and the reported incidence was somewhere between 14 to 17%, whereas the more recent studies report the number to be somewhere between 40 to 44%. But if we look into these studies more minutely, these earlier ones mostly reported on the basis of some immunofluorescence based methods, whereas the recent ones have been using RT-PCR. So that does make a difference. Overall, if we talk about the reasons for increase, there might be a true increase in incidence. We don't know yet. There is an expected reduction in incidence of vaccine preventable bacterial infections, and in some countries it has already happened. There is increased availability of molecular tests, so we are going to diagnose them more and more, and there might be a heightened awareness, which I have already shown. This brings me to the third pathogen that I wanted to talk about, and for those of you who are not aware, this is a picture of the Yeti or the Bigfoot, as some people like to call it. Now, this is a monster which we keep hearing about. People have seen the silhouette of this monster, some have seen the footprints. But if you talk to people in person, none of them actually agrees that they have seen this monster up close and in person. And this is somehow what appears to be the case with Mycoplasma. There's actually a systematic review which has been which is actually devoted to finding out the trend of research related to Mycoplasma, and the authors here show in this chart that there is a exponential increase in literature related to Mycoplasma pneumonia. Apart from the fact that cumulatively the literature is increasing, which is expected, there is also an increase in the yearly published articles. And this is a density plot that shows the literature coming out from various countries. And here we can see that as much as 34% or 1/3 of the entire literature has been contributed to by China, followed by US, whereas all the other countries, including India, are lagging far behind. What we already know about Mycoplasma is that it is probably commoner in older children and children more than 5 years of age. The pneumonia is expected to be mild, and it may cause epidemics every 3 to 7 years. If we believe the literature currently coming out of China, their current focus is on the pathogenetic mechanisms, which is not yet clear. They are still struggling with good and robust diagnostic techniques because culture and serology are not good modalities, whereas PCR may detect pathogens when they are not actual causes of the pneumonia. They are actually reporting a lot of macrolide resistance, and they have started looking at fluoroquinolones and doxycycline for treatment of Mycoplasma. They are also coming across refractory pneumonia more commonly. So this is something they label when there is no response to adequate treatment after 3 to 7 days, and it is associated with systemic inflammation kind of picture and a higher mortality. There's also a concern that in long term, there is a risk of other respiratory diseases, including asthma and other wheezing disorders. And something that we have read about since childhood, that there are extrapulmonary complications, including hematological, neurological, and dermatological. So this is what we currently know about Mycoplasma, but a lot yet remains to be seen. And this is the status of macrolide resistance Mycoplasma. More than 80% of the literature is coming out of China, some of it from US. But if we look at India, Africa, and South America, almost zero data. This is as late as 2022. Lastly, there are a few other pathogens for which there is no definite data, but I am sure all of you have experienced and know that they are emerging problems. Adenovirus is something that we have started seeing more and more commonly over the last 3 to 4 years, not only because they can cause severe disease in young children, but because there is a long-term residual sequelae, which we call as post-infectious bronchiolitis obliterans. There are some concerns that group A streptococcus or Streptococcus pyogenes is becoming more common. It causes, as strep pneumonia goes down, it causes more severe disease and more commonly associated with empyema. Bordetella is a rising concern in high-income countries, mostly because they have switched to acellular pertussis vaccine, where the immunity fades much earlier. And another important TB to talk about is the hypervirulent or multi-drug resistant Klebsiella pneumoniae, which is also coming from the community. Lastly, the way that we are looking at pneumonia is also changing. While earlier we used to think that the lower airway is a sterile site and pneumonia is caused when there is an invasion by an external pathogen. The current concept, which is a changing concept, says that it is actually a dysbiosis between the existing organism. So it is not strange that we are isolating more and more pathogens from the same individual. It might actually be that more than one pathogen is the actual cause of pneumonia, and more than one pathogen may be associated with more severe pneumonia. So overall, if I had to summarize, viral causes of pneumonia for the past few decades continue to be the commonest and may even increase further in the future. For our own context, the national impact of PCV is yet to be seen. I'm sure we'll see this in the next 3 to 4 years. The other emerging pathogens which we need to carefully watch out for include mycoplasma, adenovirus, and other resistant bugs. So I'll end with this, and I'm sure all of you have come across this picture somewhere, which says that fever is not a sign of ceftriaxone deficiency. And in view of the increasing viral incidence, I think we can safely add that fever with cough is not a sign of ceftriaxone deficiency. Thank you.
Thank you, Dr. Ketan, for that very, very informative and exhaustive talk on the burden and the like epidemiology of pneumonia. Now I would take up all the questions at the end. Now I would like to invite Dr. Ansula Tayal. She is a consultant in pediatric pulmonology and intensive care, Manipal Hospital, Goa. So she'll be talking on newer diagnostic modalities in pediatric pneumonia. Over to you, Dr. Ansula.
Thank you, sir. Are my slides visible?
Yeah. Yes. Yes, please.
Good evening, everybody. I would like to thank IAPNRC, Dr. Rawat sir and Dr. Modi sir for giving me this opportunity to speak on World Pneumonia Day. So after Dr. Ketan's informative talk on what usually causes pediatric pneumonia, we are going to briefly discuss how do we diagnose. I'm only going to touch upon the updates on the diagnosis of pneumonia. So briefly, I would talk about the challenges that we currently face when we try to isolate an organism, and roughly the role of serum biomarkers and another upcoming modality of lung ultrasound, and multiplex PCR, which is a rather controversial topic, but I would briefly talk about where does it benefit and in which situations we should avoid using it. And then lastly, I would talk about these techniques which are actually in research mode as of now, which is metagenomic and cell-free next generation sequencing. But in the coming years, we may find them being used more and more in practice as well. And lastly, a little bit about artificial intelligence models that are being used these days, that are being studied these days for the diagnosis of pediatric pneumonia. So we all know that children rarely expectorate a good quality sputum sample. And even if we do manage to get a sputum sample, it's often mixed with upper respiratory tract flora. So if we go ahead and do a sputum culture, it often yields a very mixed kind of results, and it's not easy to identify which of these organisms actually are causal in the particular case of pneumonia. So apart from the sputum cultures, the other usual test that is done is a blood culture. Again, the positivity rate is very low unless there is a frank bacteremia. Nasopharyngeal swabs or aspirates are also used for culture and as well as for PCR, but there may be an asymptomatic carriage of various bacteria as well as viruses in the nasopharynx, which may not be causing that particular episode of pneumonia. Ideal samples for diagnosis of pediatric pneumonia are ideally bronchoalveolar lavage or a lung biopsy, but these are obviously too invasive for a community-acquired pneumonia, and hence they are hardly ever done for routine cases unless there are several other risk factors or severe refractory cases of pneumonia. So given all this, the diagnosis is often based on a clinical radiological evidence and indirect markers of inflammation, wherein we diagnose pneumonia, we may or may not be able to identify the causal organism, and we empirically treat based on broad spectrum antimicrobial agents. Now, Sir, Dr. Ketan has already alluded to a lot of studies like the PERCH study and all, which showed us which organisms were common for childhood pneumonia. This CAPE study was the largest study from India. It was conducted at PGI Chandigarh, more than 4,000 children. I just want to highlight what results they found in terms of the diagnostic tests. So they found that blood culture yielded positive results in only 2% of the cases. Nasopharyngeal aspirate culture yielded positive results, meaning yielded organisms in only 15% cases. And the blood and the nasopharyngeal aspirate cultures were discordant in most of the cases. So like we've been saying all throughout this webinar, that even though we may be able to isolate one organism, whether it's actually causal in that particular episode of pneumonia or not, remains to be seen. So we cannot always attribute a particular organism to the as the etiology. Again, multiplex PCR showed a high positivity rate of 42.8%, but etiology was confirmed based on all of the findings in only about 15 to 16% of the cases. So therefore, childhood pneumonia poses a significant challenge in terms of a microbiological diagnosis. We all know about some serum biomarkers that we use as indirect markers of inflammation to diagnose pneumonia, like a high neutrophil count, a high neutrophil lymphocyte ratio, a lower hemoglobin, a higher platelet count. All these basically indicate an acute inflammatory response, and higher CRP and PCT. So the reason why I'm highlighting this particular study was it's a recent systematic review published this year only, which showed that CRP and PCT best differentiated bacterial pneumonia from viral pneumonia based on all of the other better than all of the other serum biomarkers. However, if we took a cutoff of around 53 for CRP and 0.59 for procalcitonin, their sensitivity was just around 70% with a specificity of around 64%. So on their own, they are not accurate for diagnosis of pneumonia in clinical practice. As if we compare them with other biomarkers, they may be better, but we need to take them in conjunction with the other clinical signs and symptoms as well as other investigations. So that is more or less the role of serum biomarkers for the diagnosis of pneumonia. At best, it can give us a corroborative evidence. Alone, they cannot tell us anything, whether it's pneumonia or not, whether it's bacterial or viral. There is another, so this study also talked about salivary PCT. So far we have been talking about serum biomarkers, but this study tried to look at salivary procalcitonin, salivary interleukin 6 and interleukin 10. So as non-invasive markers, and they studied serum. So this was a case control study where they took 50 children with pneumonia and 50 healthy controls. And they took serum samples and saliva samples at the time of diagnosis of pneumonia. And they found at the time of enrollment, basically, so diagnosis in 50 children and healthy controls for 50 healthy controls. And they found that serum as well as salivary procalcitonin, interleukin 6 and interleukin 10 were significantly elevated in children with community-acquired pneumonia compared to healthy controls. They also found out that there was prognostic significance of these biomarkers. So serum and salivary interleukin 10 and serum procalcitonin were elevated more in severe pneumonia as compared to non-severe pneumonia. So these biomarkers helped to differentiate pneumonia from no pneumonia as well as severe pneumonia from non-severe pneumonia. Interleukin 6 levels, however, did not differ between severe pneumonia and non-severe pneumonia. So far, salivary procalcitonin has been studied as only in research settings, but probably in times to come, it may come as a biomarker that can be used in clinical practice as well. We've all been hearing a lot about lung ultrasound last few years, and it is an upcoming modality wherein we know that it has some advantages over chest X-ray. So a lot of all of these are systematic review and meta-analysis which have tried to look at the accuracy of lung ultrasound for the diagnosis of childhood pneumonia. And we can see that all of these have a very high sensitivity of close to 93-94% or higher with a good specificity. And when we compare it to chest X-ray, it has been shown that they have a higher, the lung ultrasound has a higher sensitivity, it has a similar specificity, and it has other advantages like it is radiation free, it may have a lower cost and simplicity of operation. Also, it can be done multiple times in a child to see the course of illness and to see how the disease is evolving. So what are the signs that we usually see? Just to give a brief overview, this is a normal lung ultrasound, wherein we see that this is the pleural line, the white line that we see is the pleural line. And this is the lung shadow. And the black part is the posterior acoustic shadow, which is the rib shadow. So behind the rib, the ultrasound waves don't travel, so we see a black part. Below the pleural line, we see several parallel horizontal lines, which are actually reverberations of the pleural lines, which are called the A lines. So this is the normal lung pattern, wherein we see a smooth pleural line, we see A lines, and we do not see any vertical lines, which are known as B lines. Now, in pneumonia, we can have several findings, some of which are shown here. So this you can see, this is a wedge-shaped hypoechoic area, which is just below the pleural line, which is different from the rest of the area. So this is a subpleural hypoechoic area, which is a sign of pneumonia. The other sign that is seen here is these specks that we can see in a hypoechoic area, these white specks that we can see. This is an air bronchogram. So, and below the air bronchogram, air bronchogram suggests consolidation. And below that area of consolidation, we see some vertical lines which are coming out from this area and going downwards, which are the B lines. And we do not see this kind of a A line pattern in this ultrasound image. So these are some of the signs that are seen in air bronchogram, in childhood pneumonia on ultrasound. Another advantage is it can pick up pleural abnormalities very early on in the course of disease. So in this particular patient, on day 1, there was only a pleural irregularity that was visible, and later on, frank consolidation was visible. So even before an X-ray could pick up the pneumonia, if there are clinical signs and symptoms, an ultrasound may pick up the radiological abnormalities earlier. So these are some of the advantages of a lung ultrasound over chest X-ray. Of course, it needs a little bit of training, but with a short learning curve, accurate diagnosis can be made if a lung ultrasound is used routinely. So we all know about the conventional microbiological tests that are used for the diagnosis of pneumonia, like the sputum culture, bowel fluid culture, serum antibody tests, and galactomannan tests if we are suspecting fungal pneumonia. But there are now upcoming tests, which are molecular tests, which Dr. Ketan has also alluded to, which the commonest of them is the multiplex PCR, which can be performed on nasopharyngeal swab or aspirate, or even on the bronchoalveolar lavage fluid. Now, multiplex PCR is as the name indicates, it's a PCR wherein we put in the sample and we put in a lot of primer sets, which are specific to multiple organisms. So suppose a PCR panel is looking at 10 organisms. So it will have the primer sets to each of those 10 organisms. All of these will be mixed in the PCR mix. And after the processing, we will get a gel electrophoresis pattern wherein whichever primer sets, whichever DNA was there in that sample, the primers would hybridize to it and we would get a signal on the gel electrophoresis. So if a panel is testing 10 pathogens, out of them, if 2 or 3 are present in that sample, the nucleic acids are present, it will give us a positive result. So the advantages are that it has a rapid turnaround time. So if we make a faster diagnosis, we start appropriate treatment, it leads to shorter duration of stay. In some studies, it has been found so. Also, it gives us an information about antibiotic resistance as well. For example, in the multiplex PCR panel, with Staphylococcus aureus positivity, it shows us presence or absence of MEK-A gene. So if MEK-A gene is positive, it indicates that this is a methicillin-resistant Staph aureus or an MRSA. So we can accordingly change our antibiotics. It is specifically beneficial for viruses and atypical organisms like Mycoplasma and Chlamydia, which are otherwise difficult to culture and difficult to isolate. And also, it helps us in antibiotic de-escalation. So after a multiplex PCR, if we find that only viruses have been isolated, 1 or 2 viruses, and there's no bacteria or atypical organism, it can help us to de-escalate or narrow the spectrum of antibiotic that we are using. So it helps in appropriate antibiotic usage. But having said that, there are a lot of caveats with multiplex PCR. So like we have been talking earlier, this will not differentiate between an active infection and a residual nucleic acid from a previous infection. So it's possible that a child may be recovering from another viral infection. Some of the nucleic acid would still be present in the nasopharynx, and that will also get amplified and picked up in the multiplex PCR. So whether the organisms that are being shown positive in the report are actually causal or not, that need to be decided on a clinical basis. Similarly, for mycoplasma, it can be detected from the nasopharynx of asymptomatic healthy children as well. So always detection of mycoplasma on a multiplex PCR does not indicate a causality. With respiratory viruses, usually in children, there is low probability of asymptomatic colonization. So if they are detected, they are generally accepted as causative agent, except for these viruses, the human rhinovirus, human Boca virus, and the human coronavirus. These 3 viruses typically are known for having an asymptomatic carriage in the nasopharynx, as well as prolonged shedding after a previous infection. So isolation of these may not indicate causality. And of course, we know cost is prohibitive, so we cannot use it in all the cases. Similar to this multiplex PCR, other molecular methods have been developed. One of them is LAMP, loop-mediated amplification, which is an isothermal method. It does not use a thermal cycling. So the advantage is it's simplified, the time to detection is even lower, and the equipment is more compact and less expensive as compared to a multiplex PCR. So far, it has been developed for organisms like group B Streptococcus, Strep pneumonia, and pertussis. And in this, in a particular study, it was found that it was useful for rapid diagnosis of pertussis in nasopharyngeal samples, wherein it had a high sensitivity of 96.5, specificity of more than 99%, with a very fast time to detection of less than half an hour. So far it is still in research. It's still in the research mode, but in future it may prove valuable for point of care test for diagnosis of childhood pneumonia. Now, the next part is the processes which are still under research and under development. However, these are the initial results look promising, so it's possible that we may see these being advertised in the years to come. Metagenomic next generation sequencing is a test which is somewhat similar to PCR. It is performed usually on a bronchoalveolar lavage fluid, wherein it isolates the nucleic acid of the pathogen, sequences it, and then gives us a result. Now, what is the difference between PCR and this? In PCR, we have a pre-selected panel of suppose 10 or 15 organisms. Those organisms, the primers to those specific organisms will already be there in the PCR mixture, and it will be able to identify only those 10 to 15 organisms for which the primers have been pre-selected. Whereas in this metagenomic next generation sequencing, it will extract all the nucleic material that is there in that sample. All the DNA and RNA will be extracted. So I'll show this with a diagram. So in the sample that we have put, all of the DNA will be extracted. All of the RNA will also be extracted. The RNA will be converted to DNA by reverse transcription. Out of all of the nucleic acid that is now obtained, the human nucleic acid will be removed. And finally, the organisms that are there, they will be sequenced. So whether or not we have pre-selected, whether or not we anticipated those organisms or not, any microorganism that has been sequenced so far, the genome of which has been sequenced so far, can be identified, because we are doing a next generation sequencing for all of the nucleic acid that is available after removal of the human nucleic acid. And then finally, we get the report of organism 1, 2, 3, 4 as positive. So it can detect multiple organisms with a short turnaround time. This is what they have mentioned in the studies that are being conducted. and it uses peripheral blood mononuclear samples from healthy donors as negative controls. Now, in this study, when they compared this metagenomic next generation sequence with conventional tests, they did not compare it with PCR, multiplex PCR, but they compare it with conventional tests. And the overall pathogen detection rate was much higher, more than 91% with the metagenomic NGS, as compared to around 60% with the conventional tests. For bacterial and viral infections, the sensitivity and accuracy was much higher with next generation sequencing. It was more than 85% sensitivity and accuracy. Similarly, in viruses, it was close to 100% and an accuracy of 86%. There were some limitations with respect to fungi and Mycoplasma pneumonia, wherein the next generation sequencing had a lower specificity for fungi and lower sensitivity for Mycoplasma pneumonia. So this study concluded that at best, so far, it can be used as a supplement to conventional tests, and combinations may be the best strategy. For pneumonia per se, they have not compared it with multiplex PCR, but there were some other studies where this new technique of next generation sequencing has been compared with multiplex PCR for other diseases like pyrexia of unknown origin or joint effusions and all that, and they have found much higher sensitivity than even multiplex PCR. But yet it's still evolving. So we still will see with time how this fares. Another similar technique is a cell-free next generation sequencing. So the metagenomic sequencing was using respiratory sample, whereas this uses a plasma sample. So it's non-invasive. So in plasma, we have circulating cell-free DNA. This uses that DNA, and similar to the next generation sequencing, it will hybridize it and then it will amplify the DNA and then sequence it and finally yield us the positive organisms. So these next generation sequencings can be helpful when the patient has already received antibiotic therapy before sending the sample, or the density of the pathogen is very, very low, because these are highly sensitive techniques. And the pathogen is otherwise difficult to isolate by culture. So this is just a broad diagram to show the same thing. They take a blood sample, they separate the serum, they extract the cell-free DNA from this, prepare the libraries, and then finally do the next generation sequencing. In this particular study on childhood pneumonia, this cell-free next generation sequencing was positive in 98% of the children, and diagnosis was made by this technique alone in 70%, whereas it was made by conventional tests in only 6.5%. And the results of this particular test changed management in 78%. So like I said, early results do seem to be promising. Lastly, a little bit about artificial intelligence, because we are now in an era of AI, and AI is invading every possible field. So the premise of using artificial intelligence is that assessment by doctors is time consuming, it is prone to human error, and there can be a lot of inter-observer variation. But if we use computer-aided diagnosis models, which are called CAD models, these limitations can be overcome. And it has been seen that the artificial intelligence models perform at least similar to average radiologists in numerous areas of biomedical imaging. So they have been used to interpret X-rays, ultrasounds, MRIs, CT scans, and various biomedical imaging. Now, the particular branch of artificial intelligence or machine learning that is utilized in this is deep learning. The reason I'm talking a little bit about this is we may read a lot about this, so we should be able to understand what it means. So this uses algorithms called neural networks. It's called neural because it is inspired by how the human brain works to learn from large amounts of data. So these neural networks automatically extract useful features from raw data. They don't need any explicit instructions from human beings. The model is trained in a way that it keeps learning and relearning based on the information that it gets. Examples include image recognition, Siri, Alexa, and chatbots like ChatGPT and Gemini AI. They are all examples of algorithms that use these neural networks. Now, to give a crude example, for example, if we, now the particular model that is used for biomedical imaging is called convolutional neural network, or CNN. It is the technology that sees an image and understands it. So if you feed a picture of this kind of a picture to this CNN model, there are several layers to it. It will process it, and ultimately it will identify it as either a dog, bird, or cat, and this particular model has identified this as a bird. So if we feed an image, we get a data in the form of the explanation or the assessment of the image that we have given. So similarly, a lot of these convolutional neural networks are now used as the standard practice for medical image interpretation. For example, interpretation of X-rays to detect pneumonia. So a lot of X-rays will be fed to this deep learning model. And then based on what information it has been already fed and how it has been trained, it will diagnose it as healthy pneumonia, COVID-19, and so on and so forth. So although this seems to be very exciting and interesting, but there are a lot of challenges associated with these convolutional neural networks. Some of them are, there can be a lot of noise and artifacts caused by various factors. So for example, if one particular model has been fed with 4,000 X-rays and 3,000 of these were of healthy patients, 1,000 were of patients with pneumonia. This is known as a class imbalance artifact, wherein the model has more of healthy X-rays, less of the disease X-rays. So it's possible that it may bias it towards the more common pattern that it has seen, or it may miss pneumonia in some of the cases because the training model that it has been given has less of the pneumonia X-rays. So similarly, a lot of noise and artifacts can be there in convolutional neural networks. Also, there is limited availability of diverse training data sets. So we need to feed a lot of X-rays to this model for it to get trained to identify the pneumonia. So they can, if we don't have a lot of training data sets, they can be false positive results as well as false negative results. And also specific medical knowledge and skills are required for accurately annotating medical images. So like we always see, whenever we look at a medical image, whether it's a CT or an X-ray, we always correlate it with the clinical picture. That is not possible so far in this convolutional neural network because it will only match the X-ray to the pattern that it has been fed earlier. And then it will give you a specific diagnosis. So the medical knowledge and skills that are required to kind of make a correlation, that will be lacking. And class imbalance and label noise that, like I mentioned, it can have an adverse effect on the performance. Label noise indicates that suppose the X-rays that were fed for training into the model, some of them were labeled wrongly. Then the model will get confused and it's possible that it may label some of our X-rays incorrectly. So there are a lot of challenges still. However, a lot of studies are going on into this deep learning and CNN models for identification of pneumonia. So again, in years to come, let's see what we find out. And then apart from the detection of pneumonia by X-rays, machine learning has also gone into the diagnosis by means of signs and symptoms. So non-invasive measures like taking a panel of different signs and symptoms, and then they fed those that information into a model, and then it gives you an output in the form of whether it looks like pneumonia or doesn't look like pneumonia. So this is a systematic review and meta-analysis which showed that this improved access to accurate diagnosis in the periphery, where there may not be access to a healthcare staff or a trained healthcare staff. If they generate these models and somebody who is just who may not be adequately trained can just feed the signs and symptoms into the model and may get the result in terms of whether there's pneumonia or no pneumonia. So a lot of studies have been done. Overall performance. So I'm just showing this for the sake of showing that a lot of studies would have which took kind of clinical features like chronic cough, fever, dyspnea, respiratory rate, and all these things. They used different AI methods, and they found overall that the sensitivity and specificity of the model was good. But again, it is still in research. Another thing that is using machine learning or artificial intelligence is this plethysmography, photoplethysmography. So it has been seen that based on the data that the PPG captures, like velocity PPG and acceleration PPG and a lot of other derivatives, if you feed all this into a model, it can give you useful information towards diagnosis of various diseases like coronary artery disease, diabetes mellitus, CKD, and even pneumonia in future. So to conclude, I would just like to reiterate that molecular methods have come up in a big way, and they help us in overcoming challenges to microbiological diagnosis. However, they have to be used with caution. Not all positivity indicates a causality. Metagenomic next generation sequencing and cell-free next generation sequencing are in pipeline. They may come into practice in future. And this is an era of artificial intelligence which may aid in diagnosis by using signs and symptoms or plethysmography or interpretation of X-rays and CT scans. But we still have a long way to go before we use them in our clinical practice. Thank you.
Thank you, Dr. Ansula, for enlightening us with all the recent diagnostic modalities and futuristic prospects as far as diagnosis of pneumonia for microbes. Thank you so much. Now I would like to invite our most respected senior IAPNRC member, Dr. Krishan Chuk sir, who is the director and head pediatrics PICU in Fortis Memorial Research Institute, Gurgaon. Sir would be discussing updates on management of community acquired pneumonia. Welcome, sir.
Thank
Over to
you. Thanks to the IAPNRC for the for celebrating this or commemorating this day and bringing focus onto pneumonia, which continues to be a big killer. And secondly, to give me this opportunity to talk about the management of community-acquired pneumonia. As you have seen in the first two talks, they have been very comprehensive and they have talked about the epidemiology and the diagnosis. Ultimately, we are clinicians and we have to manage a case, and that is what I'll be talking about. Taking from where Anshula left, there is a changing face of pneumonia from pathogen to phenotype, and a lot of it comes from the bottom line that I'm integrated multi-omics approaches, combining genomics, transcriptomics, proteomics, metabolomics. These aim to create precise individual diagnostic and prognostic tools. Now, there are limitations of the pathogen-centric model that we say we want to know whether it is pneumococcus, staphylococcus, it is RSV or what. That is will be pathogen-centric model, but it has its limitations. That, for example, one patient of pneumonia, because of pneumococcus, may have very mild disease. The other one may be dying of it. Another one may be having ARDS. So, pathogen-centric model has its limitations. The emerging concept of pneumonia phenotypes is that we should try to identify what is happening between the organism and the human body, that is the immune system. So host pathogen interaction is the core of phenotyping. So we are moving from probably pathogen oriented discussions to phenotype oriented discussions in pneumonia. Now, implications for precision medicine are that once you identify a particular type of phenotype, then you can decide what kind of an treatment this patient may get. And machine learning and AI are now analyzing clinical radiological and biomarker data to predict pneumonia phenotypes and forecast the outcomes. This truly individualizes the care. Now, immunomodulation is an example where selective use of corticosteroids, macrolides, or cytokine blockers in hyperinflammatory or immune dysregulated endotypes were seen. So you did hear of use of tocilizumab in patients of COVID who are having a hyperinflammatory state. So such things we have to kind of learn from the newer technologies. So this all is coming and coming very soon. But what we have now, let's discuss that. Management area, 2025 pediatric updates. There are not too much to discuss here. I'll go through it and see what these ITSA guidelines or the associated American Society guidelines are. Then a proposed algorithm for treating patients of asthma, which has been proposed by a Canadian group. Talk about more about mycoplasma pneumonia, the treatment part of it. Then see what clindamycin, vancomycin, linezolid indications are at the time of presentation to you, which are the patients who should receive any one of these. and the immunomodulation for which clarithromycin and steroids have been used. And finally, something about viral pneumonia and diagnostics. So management of pneumonia, this 2025 update is this. First line antibiotic continues to be amoxicillin, a question that was asked in the chat box just now. Now, amoxicillin continues to be this, but my caveat is that in those areas of the world where H. influenzae vaccine has not yet fully been covered, there probably a combination of amoxicillin and clavulanic acid may have some role. However, the recommendations continue to be use amoxicillin orally and a short course of just 3 to 5 days. Alternatives are macrolides, azithromycin or clarithromycin, although we are hearing a lot about resistance to azithromycin. I'll talk about it a little more. Duration for general patients, 3 to 5 days may be all right in an immunocompetent and fully normal child. However, in a patient where you feel the response was slightly slower, the cutoff given is that at 3 days, if still the fever is persisting, give antibiotics for 5 to 7 days. Diagnostics, of course, no routine repeat X-rays are to be done. Routine X-rays also not required. And as shown by Dr. Anshula, you can use ultrasounds. A question was asked, how early an ultrasound can give an abnormality? Well, if you look for it very carefully, as she was showing in one of the cases where only pleural changes were seen, and the next day there was changes just below the pleura, which were typical of pneumonia. So it depends on how meticulously we do it and what kind of localization we are able to get. In a 1 or 2 days of onset, we should be able to find abnormalities on ultrasound. Stewardship, shortest effective duration, always our goal. Narrow spectrum, always our goal. Now, this is indications for hospitalization from the same guidelines which I'm talking about. And they are all well-known: respiratory distress, hypoxemia, altered mental status, signs of dehydration, underlying conditions, comorbidities, unable to comply with outpatient treatment. If they are negative, you treat as outpatient, otherwise they should be admitted. And chest radiography or probably ultrasound, sputum culture, blood culture, gram staining, viral testing with or without inflammatory markers may be required. And inpatient empiric treatment, I'll come to this, table 4. Specific etiology is determined, then you continue empiric therapy if you can't make out what etiological organism it was. And if you can, of course, you'll choose your antibiotics accordingly. Now, this is the outpatient treatment ITSA guidelines, which says that if the patient is younger than 5 years, presumed bacterial cause, first line is amoxicillin, alternative would be amoxicillin plus clavulanic acid. Presumed atypical cause, first line is azithromycin, alternative is clarithromycin. And presumed influenza, oseltamivir. So this is also one test that when in the period of the year when influenza is activity of influenza is a lot in the community, we should probably presume that many of these patients are influenza and start oseltamivir. As soon as you get your PCR report, if negative, you can stop it. Now, patients who are 5 years and older, presumed bacterial infection, again, it's the same treatment plan. For presumed atypical, again, is azithromycin, clarithromycin, or doxycycline for children older than 7 years. For older children, doxycycline can be used. Presumed influenza, again, the same thing. Now, this is for the indoor patients, for the empiric treatment for indoor patients. If children are fully immunized against H flu, type B and Streptococcus pneumoniae, then we can use ampicillin or penicillin G or ceftriaxone for an indoor patient. Suspected community acquired MRSA, add vancomycin or clindamycin. We'll talk a little more about it in the subsequent slides. Presumed atypical cause, first line is azithromycin, alternative is clarithromycin, and consider adding a beta-lactam if atypical is not sure. That means something like a beta-lactam, let's say ampicillin or ceftriaxone, along with azithromycin. Some of us feel that these are very unnecessary combinations, but in a case where you are not sure whether it is mycoplasma or, say, pneumococcus, this combination may be in place. Influenza continues to be the same or and children not fully immunized against H flu. Then first line should be ceftriaxone, alternative levofloxacin, suspected community acquired MRSA, add vancomycin or clindamycin. Presumed atypical cause, first line is erythromycin, clarithromycin, and similarly, beta-lactam should be added whenever we feel we are not too sure. So suspected alternative levofloxacin in patients who are not fully immunized against H. influenzae. Alternative clarithromycin or azithromycin for children older than 7 years, you can use doxycycline or levofloxacin. So these are the unusual antibiotics in a pediatrician's armamentarium, but should be considered in appropriate situations. Now, this is the algorithm I was talking about. There is a research that's going on in Canada, who are using this. The results are not out yet, but sounded a little, let's say, logical, if not really perfect. Does the patient have large lobar consolidation? Yes, give antibiotics. Even if some of them we know can be because of viruses also. If it is, the answer is no, what is the serum CRP level this person wants to see? This algorithm says. If the CRP is less than 20, don't give antibiotics. If it is more than 60, give antibiotics. And if it is between 20 to 40, and then move on further into the algorithm. If the SpO2 is less than 95%, yes, give antibiotics. If that means we don't have much time, that is why they're saying give antibiotics even if we are not too sure yet. Is the patient tachypnic? Then we move to this one. Is the patient tachypnic? No, don't give antibiotics. If the patient is tachypnic and under 1 year of age, then you will give antibiotics. Is the patient 1 year of age or is younger, then you will give antibiotics. If yes, is the patient wheezing? Look for, does the patient have PCV 13 immunization already done? 13 or maybe 10 or 14? Then give no, if it has been done, then you will not give antibiotics. If not, give antibiotics. And if the patient is wheezing, don't give antibiotics. Now, I think this patient is wheezing is coming too late. In fact, here itself, if the patient is wheezing, probably it is very, very likely that it's a virus and we don't need to give antibiotics. So this is the algorithm which can be used or is being tried. Now, few more points here. Status of macrolides as the first line treatment of mycoplasma pneumonia. What is the status today? We are thinking, we are hearing, and we saw this first two talks talking about China being the main point from where all the mycoplasma literature is coming. And there, 80% or higher, 90% or even more resistance is being seen to macrolides. So status switch to or add a tetracycline, doxycycline, minocycline for older children, adults, typically more than 8 years, when you think it's a macrolide resistant mycoplasma pneumonia. It is when it is suspected. How would you suspect? Well, use a respiratory fluoroquinolone, levofloxacin, moxifloxacin in adults when alternatives are needed. Children will have to be mindful of adverse effects in growing children. Now, some protocols suggest that if fever has not subsided in 48 to 72 hours, on macrolides, evaluate for resistance and consider changing therapy. Now, this sentence of evaluate for resistance, I find it very, let's say, not very useful clinically, because how do we, there are no tests for it. You just, in macrolide resistance, you generally go by clinical failure. In severe or refractory cases, especially in children, adjunctive strategies such as corticosteroid or immunomodulator treatments may be considered, though this is less formally standardized, but I'll show you some algorithms for this. Here is the algorithm. This says rational stepwise approach for treatment of mycoplasma pneumonia. It is too small to be read, so I'll split it into two. Now, mycoplasma pneumonia is highly suspected, and if you're suspecting clinical features and one of the following, whether there is seroconversion and increased antibody titer or a positive PCR result. Then macrolides are recommended as first-line drug of choice, as azithromycin, clarithromycin, erythromycin, we all know that. Persistent fever or clinical deterioration after initial 72 hours. Some would probably see a lot of deterioration after 48 hours. Probably I'll think of change even earlier. So exclude other causes of pneumonia or infection at this stage. And if you have reasonably excluded them, add doxycycline or ciprofloxacin. So the doxycycline will be given for 10 days, ciprofloxacin from or even longer than that. Now, going on further, persistent fever or clinical deterioration continues after you have changed the antibiotics, even 7 days after total of 3 days of azithromycin or 4 days of, let's say, doxycycline. Patient continues to deteriorate. And this season, we have seen such patients. Earlier on, mycoplasma was not that very common, but last year at least, we have been seeing many of them, and we have landed into this situation off and on. Exclude other causes of pneumonia or infection. Consider refractory mycoplasma pneumonia if the levels of LDH are very high. Cutoffs have been given like something like 300, 280, some such levels, that if such a situation you have reached, add methylprednisolone in the dose of 1 milligram per kg per dose 3 times for 3 days. If the patient continues to deteriorate even after that, then IVIG or a pulse of methylprednisolone. So this algorithm, although may not apply to every single case, gives us an idea as to how we should be proceeding in our patients. And again, emphasizing that yes, immunomodulation is in place in patients of pneumonia. Next question that comes to our mind very often is when to add clindamycin at the presentation itself. When suspected Staphylococcus aureus pneumonia is there, very obvious, but then how do we suspect? Add clindamycin if post-influenza pneumonia, classically due to Staph aureus, often MRSA. So if the patient has a post-influenza pneumonia and comes to you, think of Staphylococcus and add clindamycin from the beginning. If you see necrotizing pneumonia on chest X-ray or a CT, cavities, pneumatococcus abscesses, go ahead. Empyema or a lung abscess on presentation, go ahead, add clindamycin. Not just pneumonic infusion, we are talking about empyema. Severe, rapidly progressive pneumonia with septic shock, add clindamycin for its antitoxin effect also. History of MRSA infection or colonization in the patient or a close contact, again, clindamycin. High community prevalence of MRSA in the community that you're serving. If the levels of resistance seen are more than say 20% or so, probably you should be giving clindamycin from the beginning. The rationale is that clindamycin inhibits toxin production, PVL toxin, etc., and covers for MRSA in susceptible areas. Second, aspiration pneumonia, we'll be adding clindamycin. Add clindamycin at presentation if pneumonia follows a seizure, unconscious patient, poor gag reflex or vomiting, smelling sputum or lung abscess, probably we should be adding for anaerobes. Right lower lobe or posterior segment involvement suggesting aspiration. Poor dentition or gingival disease, again possible anaerobes. Rationale is clindamycin gives good coverage against anaerobes for oral cavity. Third indication, empyema or complicated parapneumic effusion at presentation. Fourth, when there is strong suspicion but uncertain organism, there also, and one clue can be that there is multilobar consolidations. Cavitation and of course are more specific, but multilobar patches, large patches, is also an indication that it could be Staphylococcus. That was about clindamycin. Now, when do we add vancomycin at presentation itself? Severe or necrotizing pneumonia? Of course, when it is severe, necrotizing, rapidly progressing pneumonia with multilobar infiltrates, cavitation, pneumatococcus on chest imaging. Necrotizing changes or empyema at presentation in a community where you know that MRSA is very common. Second is post-influenza pneumonia. Again, Staph aureus MRSA is a classical cause of post-influenza bacterial pneumonia. Third for indication for vancomycin, history or epidemiological risk factor for MRSA, known MRSA colonization in the skin or nails, or suppose the osteomyelitis is something the patient is already having. Recent MRSA infection, skin, soft tissue, community outbreaks or high local MRSA prevalence in the community that you are serving, and recent contacts of sports, crowded living, or IV drug users in older adolescents. Severe CAP requiring ICU care, probably vancomycin is in order. When to add linezolid. Now, this is very rarely required. To me, it is a reserved drug reserved for vancomycin-resistant organisms, or may be considered in clinical failure with vancomycin teicoplanin if other possible causes have been ruled out. Vancomycin is not tolerated. This is seen in occasional patient, and if the renal function is bad and teicoplanin is the choice, but there also linezolid can be considered. Now, clarithromycin as an immunomodulator. There is an adult study. This says clarithromycin for early anti-inflammatory response in community-acquired pneumonia in Greece, and this is called the ACCESS trial. It's a randomized, double-blind, placebo-controlled trial. That means a good quality one, published in January 24. 68% of clarithromycin group and 38% of the placebo group reached the preset goal of improvement in 3 days. Clarithromycin was added from the beginning. So conclusion is addition of clarithromycin to standard of care enhances early clinical response and attenuates the inflammatory burden of community-acquired pneumonia. Mechanism is through the immune response and not through killing of mycoplasma or something. Now, unanswered questions about this that I was able to think of were about this study. Would this same strategy work in children also? This is an adult study. Or would it be even a better effect because mycoplasma is more common in children? Or worse, we don't know. Would this strategy increase abuse of antibiotics as many cases of CAP are viral? Or we know that most of them respond to azithromycin, to just amoxicillin. Only cases of severe CAP who were hospitalized were included in this study, and would this benefit OPD patients? We don't know. And can we use azithromycin in place of clarithromycin for the same effect? We don't know because the study studied only clarithromycin. Now, what about role of steroids in severe pneumonia? Yes, if there is severe pneumonia and patient has severe ARDS, possibly yes. If there is severe pneumonia and a severe shock, possibly, clearly yes. Now, we are talking about pneumonia without a shock. So comparative effect of different corticosteroids in community-acquired pneumonia and network meta-analysis were done, and this is also a recent 2025 publication. Again, it's an adult study. And the conclusion is, in the evaluated corticosteroid regimens, hydrocortisone may be an effective measure to reduce all-cause mortality in patients of severe CAP. But we must also remember that when it came to COVID, it was dexamethasone which proved to be the corticosteroid of choice. So if it is a bacterial pneumonia and you have landed up in a stage where you want to use a steroid, probably hydrocortisone should be your choice. Duration of antibiotic treatment, I've already told you 3 days, 5 days, 7 days. Approach to adenovirus positive nasopharyngeal swab. This is something that was a lot of discussion on this in especially the eastern part of our country, where adenovirus has been isolated for the last 2 years very often in very, very severe cases of pneumonia. So first is confirm the test type. PCR is most common. It detects viral DNA, as was told, very sensitive, may detect old infection. Antigen or culture detects live virus. So culture is confirmatory, but is rarely ever done. Yes, for the purpose of research, yes. For epidemiologic purpose, yes. Assess clinical context, compatible symptoms, fever, cough, conjunctivitis, pneumonia. Conjunctivitis is a clue. Unexplained severe disease, ARDS, hepatitis, myocarditis. These are also clues of adenovirus. Immunocompromised host, yes, possible. So in such patients, probably we should be using an anti-adenovirus treatment. So third step would be interpret the NP result carefully, confirm the evidence, and then clinically integrate and decide whether you want to use an antiviral for this or not. Now, another question is, again, talked about a little bit in epidemiologic section, that superadded bacterial infection in the case of viral pneumonia. There is a viral pneumonia and a patient has a superadded bacterial infection. When do we suspect it? When there's a worsening fever, cough, respiratory distress, several days after several days after initial improvement or stabilization. So initially patient had stabilized and now starts worsening. Presence of purulent sputum, new onset of worsening productive cough, and pleuritic chest pain. Pleuritic chest pain, again, a great indicator of a bacterial infection which has set in after a viral infection. Elevation of neutrophil count, yes, we all know that, CRP and procalcitonin. So in a patient who's not improving or worsening, all these tests should be done, and then we try and come to a conclusion whether a superadded bacterial infection has occurred or not. Cultures of blood, sputum, and bronchial lavage whenever indicated, and serial chest X-rays revealing new or progressive lobar consolidation. A progressive lobar consolidation or a new patch now developing, especially if it is unilateral, or air bronchogram strongly suggests a superimposed bacterial infection in large consolidations which are because of viruses. Yes, there can be air bronchogram, but more often it is seen in bacterial infections. So these are the indicators where you would possibly use, add an antibiotic if you are not been using, or change if you are not, if you are already been using. Of course, if there is cavitation necrosis or unilateral pleural effusion, it is started after a while in a patient of otherwise being treated as viral pneumonia, now you would add antibiotics. CT scan, if it showed multiple thin-walled cavitary nodules, certainly think of bacteria which have invaded now. And GSM PCR have been talked about. I have brought it here just to say that these may be the ones that we will be using in future to sharpen our antibiotic regimens. Now, one point about this clindamycin D test. We have been talking about D test. A question came to my mind. Now that we have Vitek available, all our reports come with the Vitek culturing and sensitivity, then D test, does it still have a role? Here is the answer. Vitek result, if it is showing, we will test for erythromycin and clindamycin. Case A option is where erythromycin is sensitive, clindamycin sensitive. Then clindamycin is sensitive and D test is not required. So when Vitek is saying both sensitive, D test not required. Now, let's come to this situation. Erythromycin resistant, clindamycin resistant, Vitek saying that. Then take it that clindamycin is resistant and D test again not required. When one is showing sensitivity, like erythromycin shows resistance, but clindamycin shows sensitivity, it is here that we have to perform the D test. And if D test is positive, then it's a inducible resistance. This should be reported as resistant to clindamycin. If D test is negative, no inducible resistance, clindamycin can be used. It is clindamycin sensitive. So this was one question that came to my mind. I thought we can put it here because this guides us in our treatment. Thank you so much. Thank you for focusing on the pneumonia through this seminar on World Pneumonia Day, November 12th. Thank you, IAPNRC.
Thank you, sir. Thank you for a very, very wonderful presentation covering all the aspects of management of community-acquired pneumonia in different situations. Sir.
Yes, thank you very much. All the speakers have done a great job. And before we open the house for questions, there are quick couple of questions to the faculties, to Dr. Ketan Kumar and Anshula. As you are trying to tell, more and more etiology is now virus and probably mycoplasma. So what a clinician should do when he manages a child with pneumonia, like for example, you are telling that if you do PCR to know etiology, because blood culture may be negative in about possibly in about only 2% cases. You cannot do BAL in all cases, and your NPAs, they will detect colonizers. So should clinician do an upper respiratory or nasopharyngeal PCR or not? Because sometimes you are in a catch situation where it is a severe pneumonia. You don't know what is the etiology. So should a clinician do PCR on NPA or not, or he should do on BAL? Question to either Anshula or Dr. Ketan Kumar.
I'll take that, and I think Dr. Anshula mentioned this briefly. So the role of BAL will not be there upfront in any of the patients, I would say, until unless the patient is already known to be immunosuppressed and you know that there is very less time. That is only we'll do a BAL upfront. Otherwise, BAL will only come later on in the course. Now, before we go for any test, the idea is to first try and diagnose clinically. So what I personally feel helps us most is that there is an outbreak like situation. If you are actually getting 2 3 children per day or 10 15 children per month which are actually young from the community, it is very unlikely that it's a bacterial cause. If there is a sudden increase, it is very likely to be a viral cause. Then you look at the clinical condition of the child. You think that the fever has gone away after initial 1 to 2 days. The child is tachypnic but is still able to feed, is playful. There are exceptions to this, of course. There are severe cases of viral pneumonia as well. As and when you think, like Sir showed in his algorithm, as and when you think that the child is sick enough and you need to escalate, definitely go on, add an antibiotic. I think with the kind of availability of resources currently in our country, the role of a multiplex PCR is still in de-escalating rather than actually diagnosing. So suppose you have a child who has been running fever for 5 or 7 days and you have treated him or her adequately in your own opinion. There is no further worsening, but fever continues to stay and you don't know what to do further. Then that is a point at which you can actually do a PCR and see if you are isolating something which has not yet been covered. But I don't know before that how much useful it is going to be. Other panelists can add.
Dr. Anshula?
No, I completely agree with Ketan sir. So definitely, first of all, clinically, as far as possible, like even Dr. Chuk sir has alluded to, based on the clinical findings, based on radiology, we are able to have a broad idea of the organism. Of course, bronchoalveolar lavage is restricted only to very selected specific cases. Apart from that, the other samples that we have, sputum and nasopharyngeal aspirate culture, if possible, if we get a good quality specimen, that would be the first line. If affordability is not an issue, if we are not able to identify the organism on culture, or if the child is progressing, worsening clinically, then we could go ahead with a multiplex PCR. Again, it identifies viruses more commonly. So management wise, the only help it may give us is in de-escalating the antibiotics, because so far we don't have any therapeutics for most of the viruses.
Thank you very much. Chuk sir, yes, sir.
Two
Please, sir.
points. One, Dr. Ketan very rightly said, if there is a lot of cases coming from the community of similar type, I take one or two examples that if, sorry, sorry, my phone is ringing. Okay. So if within a family there are many members having a concurrently having respiratory symptoms, chances it's a viral infection. If there is a lot of runny nose and a watery runny nose or a thin mucus, it is likely that it's a viral infection. So these two indicators I have put it in my mind that these probably should help me decide whether it's a viral or bacteria. Now coming to the BAL and the multiplex PCR on it, I have been doing because we have a very active bone marrow transplant unit. We have lots and lots of patients who are immunocompromised, and that's why we have to do lavages very often. What we have found, whenever we do a lavage and we are sending a BAL for multiplex PCR, of course, a routine culture is being sent. There is no good concordance between them in many cases. Not always, but one may be showing pneumococcus, other shows staphylococcus, it may be showing gram positive, other may be showing gram negative. How to interpret is very difficult. We continue to take as the standard culture as our routine and the gold standard. But with PCR coming, and it becomes very difficult to ignore that finding in a patient who's immunocompromised. So for the time being, PCR, multiplex PCR, let us be kind of conservative in applying it to every patient and be careful in over-interpreting it.
Sir,
Thank you, sir. Sir, in our practice, Chuk sir, the doubt arises when to use amoxicillin in a child who is admitted in the hospital. Amoxicillin plain, amoxicillin normal dose, amoxicillin high dose. There is a lot of confusion where you use high dose or where to use normal dose or plain amoxicillin. So what is your guideline?
So I'll come to these three later. First is that if my patient is admitted in the ward also, not in the ICU, if it is admitted, we usually use ceftriaxone. Reason generally is that it is the venous thing is better tolerated and causes less of thrombophlebitis and such things. I'm not saying that it is in any way definitely better than amoxicillin. Then once a day dose also, or maybe twice a day dose also is a point. But if it comes to these three that we are talking amoxicillin, probably ampicillin would be my preferred one, because amoxicillin again is a quite irritant to the veins. If it comes to amoxicillin plus clavulanic acid, as I said, if most of our patients have received HIV vaccine, HIV vaccine, which means that used to be a reason for adding clavulanic acid to amoxicillin, because there were quite a few of those which were resistant. And now that generally doesn't happen, so we are not fond of adding clavulanic acid to in our patients. The third is that sometimes availability of amoxicillin becomes a problem, and that is why you'll end up using the combination of clavulanic acid and amoxicillin. The last point, when do we use high dose? I don't believe in high dose. Either use a normal dose or use another antibiotic.
Okay. And sir, last question to before we open the question for house is that you have told regarding use of vancomycin. Now, vancomycin is a good drug for MRSA, but doesn't have an antitoxic effect. So, a child who is having MRSA or CMRSA which is producing a lot of PVL toxin, in that case, is it a good idea to combine vancomycin along with clindamycin, because clindamycin has an antioxidant effect, whereas vancomycin doesn't have. So a child who is having severe CMRSA, giving only vancomycin will not cover the PVL producing toxin. So do you think that a combination of vancomycin plus clindamycin would be more rational?
Absolutely agree with you. When such a patient comes who's very, very severe, very toxic, and may or may not be in shock, but looking very toxic, we would start both, send cultures, and culture will generally take at least 2 days. For first 2 or 3 days, for its antitoxemic effect, we would continue to give clindamycin, even when we know that it is resistant, that it's MRSA, and clindamycin is not working in that sense. We'll continue. Once the report comes, if it is sensitive, we'll continue clindamycin, stop vancomycin, and if it's converse, we'll do the converse.
Yeah, thank you, sir. Dr. Modi, you can take a couple of important questions.
Yeah, we'll start from the last. Where we don't have confirmatory diagnostic facility, but the diagnoses have been made on clinical grounds, then Vanco versus Clinda, who is to consider, as for both indications are more or less similar?
Well, my answer taken from a textbook or a review article would be that if you're coming in the community, there is about 20% or more of resistant staphylococcus going on, probably you should, but who knows, none of us has good data about our own community, what to talk about. So that is not a good answer. The answer that I would think is practical is that both can be used, but if you are getting a lot of patients in your own say ICU and the wards, who are turning out to be failures with clindamycin or proven MRSAs, you can use both from the beginning for 2-3 days. Once the cultures are available, you can decide which one to continue. That is one way of going about it. The second, of course, we have to think that there should be no nephrotoxic thing, and vancomycin is nephrotoxic. Of course, has some ototoxicity and other toxicities also. Sometimes causes red man syndrome, not very unusual. So these things also to be taken in consideration in choosing whether to use clindamycin or vancomycin. I have burnt my fingers several times by using clindamycin more often, because believing that the kind of patients that we are getting are mostly not MRSAs. Another clue is that, like, for example, I get patients from, let's say, 4 or 5 centers. I know that when they're coming from this center and the patient has been admitted there for 2-3 days, chances are it will be MRSA. Because we know that in their center, what kind of hygiene or what kind of anti-infective measures they take. So that also I take into consideration when I am choosing between vancomycin and clindamycin.
How to handle Clostridium difficile colitis if we are using clindamycin?
We were always taught that right from my undergraduate days, which when many of you were not even born, but I have not seen it often. Again, we see a lot of this Clostridium difficile in our immunocompromised bone marrow transplant patients. and we know how to handle it. We know how to recognize it. We know how to test it immediately. So it can't be that we are missing it just now. So yes, if it is suspected, if it has happens, then we follow the standard treatment for it. Oral vancomycin and metronidazole are the treatments.
Sir, when to suspect measles pneumonia and how to test for it and what is the management?
I think that answer should come from maybe Dr. Ketan. I have not seen this.
Dr.
I'm
Ketan.
working in private sector. I don't see this kind of
So
patient.
the same thing like other pneumonia, sir. So first you need to ask for any case of suspected measles in the vicinity, in the family, in the school. If there is one, there is definite chance of the child having contracted measles. You need to look at the child where there is any recent onset of exanthematous rash. And of course, we also don't see measles pneumonia very commonly, but there are sometimes outbreaks. And I believe measles pneumonia does not start concomitantly with the rash. So if the child starts coughing 3 to 4 or 5 days after the onset of fever and rash, that's when you do an X-ray, you see if there are any changes. And in case there are, you definitely go ahead and add an antibiotic because there is an increased risk of strep and staph pneumonia. I think this is what I can say.
I think there are three angles to measles pneumonia. Pneumonia per se, measles, then post-measles pneumonia, and measles complicated with a bacterial pneumonia simultaneously. But how to differentiate?
So why is it so important to differentiate? I mean, most of these cases, you will, the idea of differentiating is to strengthen our treatment, right? And in any child with measles and having cough and fever, you would not err on the side of not giving an antibiotic. You will definitely give an antibiotic and see how
Absolutely.
we response.
In viral pneumonia, what is the protocol of management for OPD and IPD patients?
Protocol of management, you think, again, the point is, if we are taking it as a viral pneumonia, most often in the initial stage, we will not be giving an antibiotic. Oseltamivir, as I told you, if the suspicion, if it's a season of influenza, certainly add upfront. Withdraw once you get a negative report. Otherwise, no other, in an immunocompetent child, the other viruses are not treatable. So let's not talk too much about it.
Sir, about a newly available drug or vaccine for RSV pneumonia, sir. Some few words. One of our delegates, he wants this.
Nirsavimab is a monoclonal antibiotic which prevents RSV, does not treat RSV. It is a passive immunity what it gives. So in that sense, it is a immune blockage and does not treat once a pneumonia has occurred. It is not a treatment. Yes, it has been found to be better than pembrolizumab, which has been there for several years. Better in the sense that only one shot can work for several months. Of course, it's more costly. Again, it has its limitations. It's not something very great. There is a limited number of patients who are going to benefit and who are real candidates for it. No matter what the hype about it, that is not true. We need to look at those graduates of an NICU who we know have difficulties in the first few months of life or first year of life or first 1.5 year of life, where if they develop in pneumonias, and we know that by the data shown by Dr. Ketan, it is RSV which is most common, then of course we have a point in trying to prevent that, but it's a preventive medicine.
Of late, you must have used in some cases, I think.
Again, it's only in such very few.
Sir, if there is no patch on X-ray, can oseltamivir be used if the child is breathless?
Yes, certainly. Oseltamivir is for treating influenza. Influenza can cause not only pneumonia, it can cause bronchiolitis. And if it is a severe bronchiolitis, you can use oseltamivir. And it's not necessary that every pneumonia patient on the day 1, 2, 3, when we have done an X-ray, will show a clear-cut patch. May not be seen. There may be very small patches or bronchopneumonic shadows, which may be very difficult to interpret in a patient, especially when the exposure has not been great because of a non-cooperative patient.
A few questions about severe pneumonia, sir. In severe pneumonia, how long is the duration? Recommended
Again,
duration. Previously,
the-
we used to be taught like 14 to 21 days if it is staphylococcus pneumonia. Now, what is the
It
recent
continues to
most?
be that, sir. Dr. Modi, you are absolutely right. 2 to 3 weeks is minimum if it is a staph pneumonia. There is nobody saying that for a staph also you can use. Only thing is that how quickly we can come to from IV to oral. That is being debated. But duration for staphylococcus not being debated, at least not yet, with the current antibiotics. When it comes to non-staph severe pneumonia, there the guideline that was being given that after 3 days, if you are not yet seen a clear, let's say fever has not gone, it should go. For a pneumococcus, 3 days is enough. If it has not gone, take it that you need to extend your treatment to, let's say, at least I would give it for at least 7 days.
The severe RSV pneumonia, is there any antiviral that you can use, sir? And how effective they are?
Normally not required, not used, not practical. Ribavirin is a drug which is accepted in even in oral form in patients who are immunocompromised, with the caveat that it may not be a great drug, but then you have nothing better, so you would give it.
We have probably taken up this question in your presentation. Hydrocortisone or methylprednisolone for severe community acquired pneumonia in children.
You see, my belief over the years has been that all of them are interchangeable. One study says this, one study says that. But then if there is a recommendation by a guideline or something, then let's follow that guideline, even if you know that in our heart that probably they are similar, at least probably. But then when it comes to what should we follow, we should be following what is being recommended by a guideline. So if hydrocortisone is not exactly the guideline, that was a meta-analysis. But if we have that kind of evidence, probably let's go by that evidence.
Sir, in our country like ours, which is endemic for TB, how to take a decision on levofloxacin in community acquired pneumonia?
Yes, that's a tricky question. Yes, generally speaking, whenever levofloxacin is indicated, doxycycline also is indicated. So I would prefer doxycycline. Of course, I know that there can be teeth problem and all that, but probably we don't follow up our patient for years and years. We could be wrong. But given for, say, 5 to 7 days that we would be using in a, say, mycoplasma, it may not have too much of a effect and too much of a bad effect. Probably we can use doxycycline. For example, when we have been using it in, for example, in scrub typhus or leptospirosis, where if azithromycin doesn't work, then levofloxacin is not a choice, it is doxycycline. So we use doxycycline there. So probably something that can be applied here, but again, please don't quote me.
Sir, how many days of illness should be there to expect lung ultrasound changes?
That I
in
said in my talk also, that within a day or two, you should be able to. That means by the time patient presents to you, consolidations also, you may totally be getting a normal ultrasound. We have a publication on ultrasounds, lung ultrasound used in Lung India some years back. It was, I think, pre-COVID or COVID days that we published that. So there are good signs that you can pick up, but there are caveats. For example, if the pneumonia is deep inside, it will be totally missed. Next to the mediastinum. It is not picked up because ultrasound, by the time it reaches that kind of depth, there are so many reverberations coming back that you don't get a good picture of what is going on inside. Sometimes there may be additional problems because of which you can't do a ultrasound very well and you might miss it.
And most of the questions are related to management.
Sir,
There is
can I ask a
IVIG.
question from sir?
Sorry,
Sure.
Dr.
I
Ketan?
wanted to ask a question. So I was just curious, sir, how often do you actually have mycoplasma positive on PCRs, as in when you do? How often it is to get one positive?
So when we are not suspecting mycoplasma, that's a different story. I gave you that PCR. When it comes PCR from the nose, nasopharyngeal, or PCR from the bell, the two different things. From the nasopharyngeal, I usually do not ask for that test. Unless it's a large consultation and otherwise somebody had asked what are the clinical clues. One clinical clue is that there is a extra pulmonary symptomatology. Of course, the age group and the consolidation and all that is there. Extra pulmonary, whether it is hepatitis, myocarditis, encephalitis, these things add to the possibility that it will be a mycoplasma. Rest of it, not great indicators. So in such a situation, if I get a nasopharyngeal swab positive, I would probably treat it. When it comes to doing a bronchodural lavage, we are usually not doing it for looking for mycoplasma. Because the test picks it up, it comes occasionally. In fact, we had a patient who was immunocompromised and we were looking for gram-negative and this and that. He was having a necrotizing pneumonia and it came out to be mycoplasma. We treated it accordingly and it get better. So that will be very unusual. So mycoplasma, even in bronchodural lavage, we are not looking for it because we are not doing in such patients where we are suspecting. But I have at least 4 or 5 such patients who had a necrotizing pneumonia, clearly indicating that it is likely to be bacterial, and yet bacterial means staphylococcus or such bacteria, and it turns out to be mycoplasma. There, of course, you think of resistant mycoplasma and straight away go for doxycycline.
I will take the last question because we have gone much beyond time.
Yeah, it's almost 11.
IVIG versus steroid versus both for severe mycoplasma pneumonia. Which one you
So
will?
I showed you that algorithm. I believe that algorithm is quite suggestive. Steroids first, the ordinary 1 to 2 milligram per kg dose. The next, if it is a failure, there it was shown that 3 days you have given one antibiotic, 4 days you have given the second antibiotic, another 2, 3 days you have given ordinary dose of steroid. That means almost 7 to 10 days into the illness, the patient is already in, and now you will ended up in this kind of situation. Then a pulse IVIG, pulse methylprednisolone or an IVIG, both are good choices. Probably cost can help you decide which one. I would prefer IVIG in a patient who can afford it because generally immunosuppression with a pulse therapy of steroid is too much, and another infection coming in will be a disaster.
And what about the combination, sir? Both given.
Yes, there is probably a paper that I came across where both have been used simultaneously, but after the failure of an ordinary dose, and there probably they showed that it was somewhat better than one alone.
So thank you, sir. Thank you all our esteemed faculties to have answered most of the queries by the participants. We have gone much beyond time. So a parting summary comment from our chairman, sir, then we will, sir.
So thank you very much, all the faculties, Dr. Ketan Kumar, Anshul Tayal, and of course, Dr. Kishan Shuk sir have done a wonderful job. Pneumonia is such a topic where discussion could never end and we can go on the entire day. But definitely because of time restrictions, although a lot of questions are still unanswered, but we'll apologize to all those delegates and they can ask the question directly to the faculties. And all good things have come to the end. So this symposium has to come to an end. Thank you very much for all the delegates to be there till this time of our and actively participating. And of course, I cannot thank our faculties for the great job they have done. Thank you very much. And this has been an excellent symposium. Let us hope that all the information will prove useful to all the clinicians to manage the pneumonia more effectively. Thank you from IPNRC. Goodbye till we meet again. Thank you, sir. Thank you very much.
Thank you.
Good night.
Enjoyed
Thank
it.
you.
Thank you.
Thank you, sir. Good night.
Good night, sir.